Dr. Adams is a professor in the Department of Psychiatry and the Vice Dean of the Cummings School of Medicine at the University of Calgary. Prior to becoming the Vice Dean, Dr. Adams served numerous senior leadership positions with the Cummings School of Medicine. During her tenure, the Cummings School of Medicine opened its Student Advocacy and Wellness Hub to all learners in the faculty for counseling on academics, career planning, and mental health. The Transdisciplinary Precision Health Program also launched, advancing professional development of current and future care practitioners across Canada and internationally. Dr. Adams continues to practice psychiatry and co-leads research on the use of magnetic resonance guided focused ultrasound to treat resistant obsessive-compulsive disorder. And I'll hand it to you, Dr. Adams.
Thank you so much, Julian, and welcome everyone. And thank you so much for joining me this morning to talk about one of my areas of interest, which is obsessive compulsive disorder. Next slide, Julian, thank you. I'd like to start by acknowledging the traditional territories of the Treaty 7 region of Southern Alberta. Calgary is also home to the Métis Nation of Alberta Districts 5 and 6, and I'm especially grateful to be on these lands today and present this webinar to you. And someone was speaking earlier about what's happening in the south of us, and so again, very grateful to be on these lands and to acknowledge some of the disparity that's occurred in healthcare over many years, and a commitment to reconcile some of those disparities. And this lovely mural is up in the atrium of the medical school, and I'd encourage you all to take a look at it if you're ever wandering through. Next slide, thank you so much. Okay, so OCD, it's always helpful if you have a celebrity supporting this topic. And so I don't know if any of you saw the movie The Aviator, but it kind of speaks to the very severe nature that OCD can be, and it's really about Howard Hughes, and he did suffer from OCD, a very severe form of OCD. And so again, The Aviator sort of speaks to that, as well as this book on the life, legend, and madness of Howard Hughes. And what's so interesting is that people get so absorbed in their obsessions and rituals that their hygiene can very much deteriorate because of the length of time that they spend in those routines. And I think that's very much exemplified in the life of Howard Hughes. Maybe I'm just showing my age. Anyway, next slide. Okay, general information. So I got interested in this as a resident, which was also a long time ago. And I think it's a disorder that's really been misunderstood. A lot of people talk about, oh, I'm obsessive. And many of us have obsessive traits, which means that, we're organized and it can be adaptive. That's not what we mean by the disorder. The disorder is very much where it affects your life and actually interferes with your ability to work and have normal relationships. And so that's the difference between an obsessive personality, which can be adaptive, versus the disorder. And that what we're going to talk about today is the disorder, which is very different. Really bothers me when people say, oh, it's my OCD, I like a clean house. Not the same thing. Anyway, enough. So it affects about 2% of the general population. Mean age of onset is 20 plus 9. But when I ask my patients when it started, it really can start in childhood, and they remember things as a kid, worrying about cleanliness, which is the most common form of OCD, and worrying about their toys being clean or lining their toys up in a certain fashion. And sometimes it can disappear and then come back at a later date. And so I would argue about when the mean age of onset is, but you certainly, if you ask, you can see some form of it in childhood. So again, most have the symptoms before the age of 25. It's unfortunate because we don't, despite all our efforts, not a lot of people get 100% remission. And so most have a progressive deteriorating course. Now, I think that's changing with time. And if you use the medications along with therapy, I think that we can ameliorate that. And I think we're doing a better job with it if people are compliant and understand why both medication as well as ERP or cognitive behavioral therapy is important. It's important to recognize that there's a significant genetic contribution to OCD. Our own Dr. Paul Arnold, who we recruited to Calgary, works in this domain, the genetic heritability of OCD. and it can be in adults, 27 to 47% can have a heritable cause, in kids 45 to 65%. So there is a significant genetic contribution. I don't know that we've established everything completely, but we are much further along in understanding that it can run in families and there is a heritability. Also don't want you to forget that there can be comorbid disorders associated with OCD. So the most common ones are depression, other anxiety disorders like panic and social phobia. ADHD is really seems to be coming into the fore. There's a lot more diagnosis of adult ADHD, and it can often be comorbid with OCD. Eating disorders also overlap because there can be obsessions and compulsions around food, but again, a little bit different phenotype, but there can be some overlap with OCD. And as I've mentioned, the OCPD, or personality disorder, which is very different than the actual disorder. So personality traits versus having the actual disorder are quite different. And unfortunately, 20% of patients do not respond to the first drug prescribed. And we're going to talk more about the medications that we use. And you have to try all of them because they're all structurally different. And so you have to be quite methodical in how you approach that with patients. Also want to mention that there's OCD-related disorders, and those can be body dysmorphic disorder. Someone's sort of upset with one specific part of their face, and they'll stare in the mirror for hours at their nose and be consumed by it. Another common one is hoarding, which is thought to be different than OCD, but related. People can't throw things away. I've had patients I remember one person who couldn't throw anything away that came to them by mail unless they'd read it. And that was in the days when we had all those flyers coming to our house and magazines and things, and they couldn't throw it away until they'd read it. Well, you can imagine the stacks in their house. Trichotillomania is another related disorder where someone might stare in front of a mirror and pick at the hairs on their scalp or their eyebrows or eyelashes. Excoriation disorder is another one where people will pick at their skin, again, in an obsessive way, but it's a little bit different in terms of its presentation than classic obsessive-compulsive disorder. And tic disorders and Tourette's obviously can overlap as well with OCD. So looking at the OCD symptom clusters, so the most common one that we all think about is contamination by dirt and germs. And so that is the most common obsession. And the accompanying compulsion is washing. So vigorous washing several times a day, taking up hours in the day, using excessive amounts of soap, sometimes counting to a certain number while they wash their hands to make sure it's done completely. People describe wanting to wash until it feels right, and that can take hours in a day. And that also happens in the shower with elaborate routines associated with it. Another common symptom cluster is checking. So the obsession is doubt. Was it done correctly? Did I unplug that hair dryer? Is that lock actually bolted? Those kinds of things. And so they ask for reassurance from family and friends. They go back and check a number of times. And so, as I mentioned, they might count to a certain number and have these repetitive actions and very elaborate routines around checking that their doors are locked, that their windows are secured at night, those kinds of things. Another common form of OCD, which is difficult to treat, are pure obsessions. And so these are when there are just intrusive thoughts and they go over and over and over in your brain. And I'll show you where that happens later in my talk, where it occurs in the brain. And they're repetitive and they go over and over and they're intrusive and they can't get rid of them. And often they're very ego dystonic. In other words, they're reprehensible to the thinker. So they're very hard to talk about. And if you don't ask, they won't tell you about them. Often they can be related to some kind of illness or a somatic concern. They're often aggressive or sexual in nature. And again, that's why they're very difficult to talk about. And again, they're very reprehensible to the thinker and not in keeping with who they are as a person at all. The other common one is obsessional slowness, where things take so much time. And you often see this, I've heard in kids at school or, well, university students in class where, they'll have an assignment and they have to, or they're writing a test and they have to review what they've written or go over that answer again. And I think we all have that a little bit. But again, this is the disorder where it goes over and over in their mind. And I've had some of my patients who will get rid of their entire assignment and have to do it over again repeatedly. So you can imagine the disruption in their life. Next, Julian, thanks. Yeah, that's just that's the sort of classic OCD vigorous scrubbing. And I guess one of the signs as a psychiatrist I look for is red hands. And that's often very telling to know how much time they're actually spending washing their hands. It's one of the things I can look for. Okay, next. So DSM-5, we all hate it, but we all use it as to understand the disorder. And it is helpful. It's no longer classified as an anxiety disorder because it does behave a little bit differently. And again, there's biologic underpinnings. There's a part in our brain that causes these loops to go over and over again. And so again, what is the DSM-5 criteria? It's recurrent, persistent thoughts, urges, or images that are intrusive and cause anxiety or distress, and attempts to ignore or suppress them, to neutralize with a thought or action. And that's the compulsion part. So when you're very distressed by the obsessions, you do the compulsive acts to try and neutralize that very severe anxiety that you fear and that you feel. Next, compulsions. So repetitive behaviors, hand washing, ordering in a certain line, checking, mental acts, praying, counting, repeating words silently, and the person is driven in response to an obsession. And the behaviors, again, are meant to reduce distress or prevent an event yet or connect it. And people can have all sorts of connections in their head that if they don't wash their hands a certain number of times, or they don't count to 10 while they're washing their hands, something terrible is going to happen to their child or to their parents. And so they make these connections in their brain because of these concerns. And that's what makes it so difficult for them to disengage from the rituals, because they're so invested in something terrible not happening to their family members. Next. Again, the obsessions or compulsions cause distress, so they're time consuming, at least an hour per day. And I'm going to tell you about the Y-BOCS score that we use in terms of the amount of time spent in obsessions and compulsions a little bit later. But to meet the DSM criteria, it has to be at least an hour a day that someone is engaged in these kinds of obsessive thoughts and compulsive acts. And you can imagine how disruptive that would be to the person's functioning. And that's the key to diagnosing this disorder. And again, it can't be attributable to a substance use disorder or medical condition. And again, they can't be explained by other things like generalized anxiety disorder, body dysmorphic disorder, the other OCD-related disorders that I mentioned. But you can certainly see them along with OCD symptoms and behave in a certain kind of a similar fashion. Okay. Next. And again, what's interesting to me is they've now specified that, so the crux of having OCD is that you do usually have insight. You do know that this is something that you shouldn't worry about. You know that it's over the top. You know that it's excessive and obsessive. And so this is what makes it very different from delusional thinking in schizophrenia. I've also worked in early psychosis, and I was very interested in that overlap. When does an obsession become a delusion? And so people that have OCD, they have insight. They know that they shouldn't worry about this. They know that they shouldn't wash their hands for the 10th time, but they can't stop. And so again, they now have a classification where OCD can become so severe that it's bordering on that, the brink of delusional thinking. And so that's when you have OCD without insight and can have delusional beliefs. And I was very interested in that intersection of when does an obsession actually become a delusion. And then you can also specify if there's any tics associated with the disorder. Next. Okay, so often I find people are very secretive about this, and if you don't specifically ask, you won't be told. They won't tell you about their rituals, their mental anguish and obsessions that are in their brain. The compulsive acts that they do, they can be very embarrassing because remember, they have insight. They know that they shouldn't be doing this and they shouldn't worry, but they can't stop. So just remember to ask, do you wash or clean a lot? Do you check things repeatedly? Again, kind of open-ended questions so you're not leading. Is there anything that bothers you that you can't get rid of in your brain, but you can't? How long do you take, to wash your hands, or how long do you take in the shower? It's just a question that might open the door. Again, concerned with orderliness or symmetry, is that important? And they might seem very rudimentary, these questions, but if you don't ask, people won't tell you, in my experience. Next. So this is a Y-BOCS symptom checklist, and it's probably hard to read on the slide, but you are going to get these materials that you can look through. And I find this very helpful because it's a list of obsessions and compulsions that you may not think about asking. And so in this list, you can see there's aggressive, sexual, religious obsessions. There's questions about hoarding, symmetry, exactness, and things that, again, twig you to ask the patient once you've determined that they have OCD. Again, they won't always tell you about some of the ones that are more difficult to talk about, like the aggressive obsessions. Next. So this is the other part of the checklist. So again, this is the compulsions part. So cleaning, washing, repetitive rituals, ordering, arranging, checking compulsions. And then if you look at the other compulsions, again, pathological slowness, need to tell, ask, and confess. And that's an interesting one. I've had patients who are often in a relationship and they have fears about their spouse having had an affair or something like that, and they have to confess almost to their partner, and they'll go over and over and over it, and they'll go back and revisit the conversation, and it can be, again, very disruptive in a relationship. So it's a good list for you to go through when you're with a patient, and so you don't miss things. Okay, next. So this is the Y-BOCS scale. Again, you'll be getting these materials. And so the Y-BOCS score is a Yale-Brown obsessive-compulsive scale. And it deals with things looking at time spent on obsessions. So as I said, for the DSM criteria, you need at least an hour. But when we look at the Y-BOCS scores and what would be considered mild, moderate, or severe, we look at the time spent. And so people can spend between 1 and 3 hours or 3 to 8 hours. And it's a big jump in that domain. And so anyone with a score of 26 to 34 would be considered moderate to severe, and anyone between 35 and 40 would be severe. So these are the domains that you look at when you're scoring this: time spent on obsessions, 1 hour a day, 1 to 3 hours a day, 3 to 8 hours a day. And people actually do spend that amount of time, and they'll say it's like the whole day, and they never get any relief from it. Interference from obsessions. So again, is it definite but manageable? Is there really impairment in their lives, or is it incapacitating? And for some patients, it can be incapacitating. And then the associated distress with the obsessions or the compulsions. Again, is it manageable, or is it really disabling? And for those patients that have very severe symptoms, it really can disrupt their life completely. And again, does the client try to resist the obsessions? That's an important factor, because some people just let it happen, and because of the ties to magical thinking about things that might happen, they'll just give in. They'll give in to the obsessions, they'll give in to the compulsions. And so the question is about resist. Do you try not to wash for the 3rd time, or do you try not to check for that extra time? And so being able to resist is really important, and it's an important part of treatment going forward. And then control over the obsessions. Again, how much control do they feel they have? Can they distract themselves? Can they go watch Netflix and not be focused on what their concern is, or do they have no control and they're just flooded by these thoughts, and then corroborating compulsive acts with it? And so again, this scale is what I use clinically, and also in our research protocol that I'll tell you a bit about. And it is very helpful just in terms of understanding the magnitude of the disorder. Okay, so I hope that's helpful. And it's got at the bottom of the Y-BOCS scale, it does tell you what is considered moderate, severe, and what is extreme. Okay. Next. So what is the pathophysiology of OCD? And this is really important because this leads to how we treat it. And so again, when I started in psychiatry, we were talking about Freud and, blaming mothers. And I don't mean that, but I kind of do. Anyway, this is actually a brain illness. This is something that is in our brain, and we have evidence for it. And so if people could stop this, they would, because they do have insight. They know they shouldn't worry, but they can't stop it. So why does this happen? So again, in psychiatry, we tend to like to say it's everything serotonin related, but it is true in this case. The serotonin hypothesis is the current explanation for the neurochemical basis for OCD. And there's lots of evidence in terms of using serotonergic drugs that we'll talk about. And also it's supported by brain imaging studies. And this is what got me interested in psychiatry. It was the decade of the brain when we were getting into functional brain imaging. Structure is fine, functioning is not. And now we're looking at dopamine and glutamate that are also important modulators in the brain. The brain is never simple. It's never just serotonin. It's also dopamine and glutamate, and that is supporting some of our more novel treatments to date. Next. Again, so where are these loops? These are these loops that go on in the orbitofrontal area, the corticostriatothalamic loop, and that's where it goes over and over and over in your brain. And I'll show you the next picture because you have to see it where it is in the brain. So it's the pink area, the caudate nucleus, putamen, globus pallidus. So it's the basal ganglia. So you don't have to know about the anatomy of the brain. All you can see is the pink part. That's the part we're talking about. So they're very deep structures where these loops go over and over and over in the brain. Next. Again, I'm a practical person, so I like to understand how this happens. So if you look at the left side of the photo, so where the putamen interacts with the motor cortex, that's where you would have tics and chronic multiple motor tics. And I've got the next slide shows, no, don't advance it yet, Julian, but it will explain all of this to you because I think you have to know where it occurs in the brain. So that's where chronic multiple motor tics occur without emotional or cognitive systems. So that's on the left side of this diagram, my left. If you have pure obsessional disorder, without any motor symptoms, so no, nothing related, just the pure obsessions, that's the ventromedial part of the caudate interacting with the limbic cortex. And then if you have typical OCD, it's the dorsolateral part of the caudate nucleus interacting with the premotor and association neocortex. That's where you get the typical OCD. Because you have to understand in the brain, how is it that we can have tics that are associated with OCD? How do these obsessions work? Where are they? And why can't they be stopped? And then if you get all of it together, where does that occur in the brain? So I hope this is helpful. Next. This is the explanation that you can read later, and it was what I was just talking about to understand why some people have tics, some people have pure obsessions without the rest, and then some have typical OCD, where you've got complex cognitive and motor behaviors in addition. So you've got obsessions and compulsions. And then I hope it explains it a little bit more to understand some of the very innovative, I think, MR-guided FUS that we're doing to treat treatment-resistant OCD. Okay, next. Let's get on to the treatment. So mild to moderate severity, you can consider cognitive behavioral therapy, which is the exposure response prevention alone. And that's often what we do with kids, not that I treat kids, but Dr. Paul Arnold does at the Children's Hospital. And they'll often start with cognitive behavioral therapy. Very important. And there is evidence to suggest that ERP or cognitive behavioral therapy alone can achieve what medication can do, but probably it's best to have both together. In moderate severe cases, we would do both. So it's always best, and the gold standard is really to have a high dose SSRI that's well tolerated, that doesn't give side effects, along with cognitive behavioral therapy. So the two together are very important. Next. So here's the medications that we use. So there's a whole list. And again, as I mentioned, they're all structurally different with different dose ranges and different side effects. And I think the failure for treatment is not approaching this methodically, using a medication for a long enough period of time at a high enough dose before you decide if it's effective or not. So a good clinical trial of a medication is 6 to 8 weeks, and some of the OCD literature would suggest even 10 to 12 weeks. So you have to be patient. Start with one agent, start it at a lower dose, increase it incrementally, pay attention to side effects, but make sure it's a high enough dose for a long enough period of time before you say it's not working. And you can see the dose ranges on the slide. So we often get antidepressant effects because these are all antidepressant medications, and you get the antidepressive effects at the lower dose. But if you want the anti-anxiety and to have the effect on the obsessions and compulsions, you need to go higher. So the higher doses of SSRIs is really what we're targeting. And again, you have to do it methodically. You do it as a partner with your patient, and you understand what they're experiencing. And I learned a very good thing from a nurse I used to work with, and she would always say, "Did you take your medication every day?" And they'd say, "Oh, yes." And then she'd say, "Did you ever miss a few, maybe 2 or 3 days?" "Well, maybe I missed 3 or 4. And it's like, okay. So you're actually not getting it every day of the week. So I really learned a lot from her. And I do ask a lot about compliance, and maybe that's not the right word, but understanding if patients are actually taking what you think they are. And I learned early on that that's not always the case. So you don't want to be increasing the dose if the patient is not actually taking the medication regularly. So some points to consider. So looking at, how do we decide which one to use? And so what I'll often do is ask if there's a family history of OCD. So if there's a first degree relative that has done well on an SSRI medication, that's what I would go with. I also have the privilege of working with Dr. Chad Boozman, who has a research protocol around pharmacogenomic testing for SSRI agents. And so it's great. I email him, he sends a spit test to the patient, they spit in the little vial and send it back to him, and I get this tremendous report, which doesn't actually tell me which one is going to work, but it gives me guidance to know what side effects the patient might experience on specific SSRI. So it's a bit of a guideline as to which one to choose, which has been very helpful. If you read the literature around pharmacogenomic testing, it's some variability of it being useful or not, but I think we just haven't quite understood the importance of it. And I certainly find it very useful clinically to understand, especially if someone has had a number of trials and they've had a number of side effects, it will give me guidance for that. So which one do I start with? I often will start with fluvoxamine, which has a lot of evidence in the literature, or sertraline. Those are two very anti-serotonergic agents, again, going up to a high enough dose. So you can see the range up to 300 for Luvox, up to 200 for sertraline. Other agents like fluoxetine, which was one of the first SSRIs to come out, which probably got a bad reputation because of that. It can be very useful in OCD. And paroxetine is another useful agent. And in terms of side effects, the biggest ones are sexual dysfunction or low libido, and sometimes a headache when you first start them, but really they're generally much more tolerable than the old tricyclics. Now, one of the medications on this list is clomipramine, which is a tricyclic antidepressant, and it can cause weight gain and sedation. It still was known as the gold standard for treating OCD. And so what I will often do is start a medication like fluvoxamine, titrate it up to a high enough dose, and then add low dose clomipramine at bedtime, because sleep is often a problem. And so the sedation, if it occurs at night, is when you want it to happen. And start with, even 50, 75 milligrams and see how it's tolerated. And you don't necessarily have to go as high with that medication if the person isn't tolerating it. So you always need to have a dialogue and understand what kind of side effects are occurring in order to have effective treatment. The other thing I tend to add with Luvox and clomipramine is aripiprazole, and that's Abilify. And I usually go 1 to 2 milligrams only. And this is a better choice than something like risperidone, because risperidone can cause an elevation in prolactin and other complications. And so I tend to use aripiprazole. It's not listed on this slide, but it's Abilify. And it's to get at that dopamine part for treatment. So you have the serotonergic agents, which are these primary anti-obsession agents on this slide. And then I add a tincture of dopamine, which is aripiprazole is my choice, Abilify. People have used risperidone, olanzapine, but again, sedation, weight gain, increased prolactin with risperidone. You need to be careful with those kinds of side effects. Again, with S-citalopram, we used to go higher with the dose, but again, you have to be careful of QTC prolongation if you go above 20 milligrams of S-citalopram or Cipralex. I've not seen that a lot clinically, but it is a sign to warn, and I believe it's one of your questions anyway. So these are the primary anti-obsession agents that I use, and again, use them appropriately. Titrate them, start low, titrate them to a high enough dose for a long enough period of time. Next. Again, okay, so I'm fear of being repetitive. Here we go. So SSRI, maximize the doses tolerated. And again, at least 6 to 8 weeks, and 10 to 12 is even better. What do you do if the first one doesn't work? You choose another one and repeat. If you've got pharmacogenomic testing, even better, but if you don't, move to the next agent, taper one and start the other, and repeat again as described. If 2 to 3 of the primary drugs aren't effective, then I consider combinations or augmentation. I'm not a fan of polypharmacy, but I think if the primary agent isn't working, in OCD, it can be very beneficial to use some combinations that I described or to augment. So fluvoxamine with clomipramine, as I just mentioned, is a very useful combination. Again, start with the fluvoxamine first, titrate it up, add low-dose clomipramine at bedtime. And then I do add aripiprazole, that's in 0.6, augmenting with other agents. And my choice is the aripiprazole that's listed in number 6. Others use risperidone, olanzapine, but I've mentioned some of the concerns that are associated with those medications. Second line agents are mirtazapine. Now, mirtazapine is excellent for anxiety, but it causes sedation and weight gain, so it's not favored by patients. Other second line agents would be venlafaxine, duloxetine, so they work both on serotonin and norepinephrine, and they can be useful in treating OCD. So again, you have to look at your armamentarium, start with SSRIs, but know how to use these medications appropriately, or you've lost your patient if you don't stay in constant dialogue with them about what they're experiencing. Next. Cognitive behavioral therapy, very important. I imagine many of you probably practice it listening to this webinar. And so the mainstay of treatment is ERP, exposure response prevention. And I worry because sometimes clients will tell me that they've had therapy and it's not working. But if it's not evidence-based and it's specific for OCD, it won't be helpful. So the gold standard of treatment is a high-dose SSRI that's well tolerated, along with cognitive behavioral therapy, specifically exposure response prevention. So again, it's where you confront fearful stimuli and you become habituated to it. So you kind of let the anxiety dissipate, and then eventually it goes away. And that's what patients finally feel a relief, and will sometimes abandon their rituals. It's so rewarding when patients feel that relief, where they actually can focus on something else in their life and can actually leave the hand washing and not spend so much time of their day in it. It's suggested that you could make a list of the patient's fears and rituals and kind of arrange them according to difficulty. Some therapists will say you start at the easiest ones and have the patient conquer those. I've heard other therapists say that they start with some of the hardest ones and then all the other ones tend to disappear. I think you have to, again, work with the patient and understand what would work for them. And I think you also have to explain what is normal behavior, because it gets lost. They feel that, washing their hands that many times a day is perfectly normal, and it's not. Again, you have to be realistic. If you've touched raw chicken and you're cooking, of course you wash your hands, but you have to educate the patient about what is normal behavior and what is acceptable in terms of hand washing. A lot of people ask me, how are my patients during COVID? But interestingly, a lot of them coped quite well, and some of them felt some validation in that, maybe it was okay to wash their hands. But again, it's a very different mode of thinking. Some of my patients got a lot worse during COVID because of their fears being realized. So it was a very interesting time, but I'd say a bit of a mixed bag in terms of people doing very well or not doing well at all. So again, just remember to educate what's normal. Next slide, 24, is cognitive self-talk. So I think while the patient is attempting the exposure, therapists would encourage some self-talk. Did I think it was a problem before? Did anyone ever tell me to worry about this? Why am I worrying about this? And then sometimes if they're just unable to engage in therapy at that time, sometimes they might imagine the exposure as a form of the next step. Maybe they'll be able to take in terms of the ERP. So if they can't actually do it in real life, they might imagine the exposure before they actually engage in it. And again, important to educate the family. I've seen lots of my patients where the family gets incorporated into the rituals. Somebody, having a shower won't allow anyone else in the family to run any other appliances while they're in the shower, as an example. Very disruptive to family life, and actually doesn't help the patient at all. It just reinforces the obsessions and compulsions. So it's very important to remember to do that. Next. So because we have such great therapists, they're in high demand, and often there's a wait list. So I've been told that this OCD workbook is very helpful, and it kind of explains why the patient may be thinking the way they do. Why do the obsessions happen? What can they do while they're waiting for a therapist of their own accord, in terms of managing some of the ERP, or even trying some of the exposure response prevention at home while they're waiting for treatment. So this can be quite a helpful workbook if your patient is so inclined. Next. So reasons for treatment failure. You wouldn't think a diagnosis would be that tough, but I've seen patients admitted to inpatient wards where patients are called psychotic, and they're not psychotic. And if you speak to them, they still have insight to know that this is over the top, unnecessary, but they're so anxious they can't stop. And I understand some of the confusion because of that close link with delusional thinking. When does an obsession become a delusion, as I expressed before? But if you don't understand that you're dealing with OCD, you may think it's a generalized anxiety disorder, or worse yet, something that's in the psychotic domain, and then you'd only use antipsychotics, which would not be helpful for a patient with OCD solely on their own. And again, the most important part of treatment failure is inadequate treatment. So an inappropriate or an ineffective medication. You haven't tried the next one. As I said, they're all structurally different, so you need to try all of them before you deem it to be a treatment failure. And then again, the trial being too short or the dose being too low. So it's very fundamental principles around medication use. And the other important part is no behavioral therapy associated with using the medication. So there's been no CBT or ERP as part of the treatment picture, and that can result in failure. Or compliance. Again, I hate to always talk about compliance. It's not only a patient factor, there's many other factors that can be part of this. And so maybe they don't understand the illness, or very helpful family members who always have an opinion about mental illness, which really gets my goat. I don't think you need those medications. Just pull up your socks and stop worrying. Really helpful suggestions like that from family can result in patients stopping their medication. The other thing I see, which is a tragedy, is that patients are actually better. They actually have relief for the first time in their life around their obsessions and compulsions, so they stop their medication. And it's like, okay, here we go again. And so that's one of the common reasons for treatment failure, is that they'll actually stop their medications. And for some reason, when you go back to the same SSRI, it doesn't always work. I don't know why that is. The brain is a complex organ. And so even though it's worked in the past, if you've had a hiatus in treatment where they've been off it for several months, even, you go back and use the same agent and it doesn't work. And I'm not sure why that is. I'm sure someone smarter than I might know why that is. Anyway, and then again, the unrecognized cognitive impairment. I think just understanding that people are so consumed by the obsessions, and they can't focus, they can't attend, they can't concentrate on even what they need to be doing. So another thing to think about. Next, alternative treatments. So again, an exciting time in OCD. All of these agents work on glutamate. And so we currently have a Biohaven study looking at riluzole as an add-on for medication. So patients will be on their same medications, and then we add riluzole. Again, looking at the glutamate story, or the contribution that it makes to the pathophysiology of OCD. Ketamine, lamotrigine, and cycloserine also work on glutamate. Cycloserine is an antibiotic, and one of our researchers, Dr. Alex McGeer, did a recent study using cycloserine with RTMS, or repetitive transmagnetic stimulation, which I'll also tell you a little bit about, and again, found some promising results in treating OCD. So again, always looking for new treatments, and that's why I think clinical trials are so important, especially in psychiatry, so we come up with evidence-based treatments for these brain disorders. Next. Okay, something I really want to tell you about is a protocol we're doing in Calgary. And if you look down this list of neurostimulation methods, it's MR-guided focused ultrasound. And it's a very innovative and novel and non-invasive way of treating very severe treatment-resistant OCD. So this is a nice table if you're trying to understand all these new ways of brain stimulation and what is helpful in mental illness. At the top, you see repetitive transmagnetic stimulation. Again, that's outside of the scalp. It's not invasive. It's used as a treatment for depression. And if you go with a deep coil, there is treatment for OCD in that regard. And the one I just mentioned with Dr. McGeer with deep TMS, as well as adding cycloserine. I won't go through all of these. You can read about them because it's helpful when a patient might mention that they'd had a gamma knife in the States, years ago. You can understand what that might mean. But I wanted to focus on the MR-guided focused ultrasound, which is second from the bottom. So it's a protocol we're doing in Calgary. They've also done it at Sunnybrook in Toronto, and there's a number of centers around the world that also use this method of treating treatment-resistant OCD. Lots of it is in South Korea as a start. But what's important about this is that it's for treatment-resistant OCD. So if you've exhausted the SSRIs, the augmentation with aripiprazole, other agents, if you've tried ERP endlessly. And so these are for patients where they're consumed by their obsessions and compulsions. They are spending over 8 hours a day with these concerns. These are the patients that are deemed treatment resistant and who we are using as subjects in this protocol. We've done 6 patients so far, in the midst of doing our 7th, and the results are amazing. And what's important to know is this technique is the same one that they use for treating tremor. So there's amazing videos of people using the same form of treatment for tremor. And you can see the hand kind of shaking before the procedure. After the procedure, their hand is steady and they can drink water. It's quite remarkable. The HBI has lots of these videos to demonstrate it. And so it's the same technique, but it's used to treat treatment-resistant OCD. And that's why I showed you the brain, and where that pink area was, that's where this treatment works. And so what they do is they use the MRI to know exactly where they are in the brain. And this is being done here by Dr. Zelma Kish, is the functional neurosurgeon, and Dr. Bruce Pike and Conrad Rockel, who look after the MRI side of the procedure. So they know exactly where they are in the brain. The brain is heated up to, you can see the degrees, 51 to 56 degrees C, and they kind of create tiny pinpoint lesions in that specific area of the brain that I showed you. And that targets those loops that go over and over and over. And it's fascinating and very exciting. Next, otherwise I'll go on and on. So this is kind of what it looks like. Looks scary, but it's not. Again, non-invasive. They know exactly where they are in the brain. There's people around all the time. Usually they can do bilateral, so both sides of the brain in one treatment. And there's medication provided, people there making sure that the patient is okay, and they make those tiny pinpoint lesions. And I'll just show you some preliminary data, the next slide, which shows the Y-BOCS scores over time. So remember that checklist that score that I showed you that we use clinically, that would be severe or moderate to severe, and looking at the Y-BOCS scores over time. So I vet the patients and deem whether they're treatment resistant or not. A second psychiatrist also sees the patient to understand and be sure about the diagnosis, which is very obvious, but also that it is treatment resistant, that they've exhausted all of the pharmacology, all the medications have been tried with augmentation strategies, with CBT and ERP, and they're deemed treatment resistant. And so we do the Y-BOCS score before, and I see them a week post-procedure, a month, 3 months, 6 months, and a year. And all the patients that we've done are so much better. It's a small N, so we're still looking to do more patients, but the results are quite remarkable. And I think what's most important is that it's about quality of life, so that their relationships are better, they're working again. They're not so focused on the obsessions and compulsive acts. It's never gone completely, but they're not having to pay so much attention to it. They're not focused on it. They're not spending 8 hours a day in it. So this is quite promising, and I'm very excited to be part of the research here at through the HBI and the University of Calgary. And I will stop there.
Thank you, Dr. Adams. That was excellent. Thank you. I'm just going to stop sharing, and that will enable me to do. I'm just going to, before we just look at the chat and the questions, I'm just going to launch the post-webinar evaluation. Which is this one. Okay. And we'll go to chat.
I hate all these blank screens. I'm a people person, so I like to see faces, but I know this is the new way.
Indeed.
Ah, yes, people. Oh, good. Oh, thank you so much. It's nice to see your faces.
Okay, Dr. Adams, I'm going to read out the questions as they came in order. And the first one is from Kelsey. Are the results from RTMS being shown to be just as effective as the pharmacological combined with psychotherapy approach?
I wouldn't say not yet. I think an RTMS alone, I don't think would be as effective. So still the gold standard is a high dose SSRI along with ERP. That is still the best form of treatment for OCD. I think we're looking at different protocols for repetitive transmagnetic stimulation, but you have to make sure it's deep coil. I showed you in the brain how deep those structures are. And so you have to make sure it's the right kind of coil for RTMS. And maybe an agent like Dr. McGeer was using, where you add a glutamate agent like cycloserine, there might be some opportunity that it would supersede how well you get treatment effectiveness with SSRIs and ERP, but we're not there yet.
Okay, question from Ashley Locke. I wondered what Dr. Adams thinks about Trintellix for treating OCD. I believe it is considered off-label use for OCD.
Yeah, so vortioxetine, I have used it. I tend to not, I do not meet with pharmaceutical companies. I was a former program director for psychiatry, and I tend not to use the latest and greatest because they come and tell you about it. But having said that, there is some evidence for vortioxetine, and I always use the generic name, which is Trintellix. And so I do have a few patients on it, and I hope that no one is concerned that I call my patients because I have a deep respect for them, and it's always a dialogue. I know some people say client, but I hope you understand my deep respect for patients. So yes, it has been shown to be helpful in OCD. I don't know if it has as much evidence as some of the other SSRIs. Interestingly, it can be useful with effects on cognition, and so it might be one that I'm starting to use a little more regularly. Some of my patients will also say that it has fewer sexual side effects, and so that might be important, depending, again, speaking to your patient and what might be important to them. So I do use it. I don't know that there's enough evidence for it, and as you say, it is off-label use, but often that's how things start, right? As off-label, but worth a try.
Okay, Amber Fleming. I know several PTs taking Cipralex 40 to 50 milligrams. What do you say, 10 to 20 milligrams?
Yeah, and that's what the literature will say, 10 to 20. And another useful agent is citalopram, which is Celexa, which is the parent compound for S-citalopram. And so we used to go up to 80 milligrams with that. But again, they shut that down. And it's often perhaps a patient that might be elderly who suffered some effects because of the higher doses. And so they've limited the dose. I do go higher with S-citalopram. And again, these are patients that are very debilitated by their symptoms. And so I do go higher, 30, 40 milligrams of S-citalopram, and there's been no issue with QTC prolongation. So I do go higher. I tend to go higher with a lot of these medications. I do have a long-term patient on 300 of fluvoxamine, 300 of clomipramine, and 2 milligrams of aripiprazole. So you have to be bold but cautious in terms of using these medications appropriately.
Okay, question from Dr. Pringsheim. Have you ever referred treatment refractory patients to the program at Sunnybrook Hospital in Toronto?
I've tried, even though Peggy Richter is a colleague, we have a lot of trouble getting people in because we're out of province, obviously. And so they're very lucky that they have the only inpatient treatment center in Canada. And so I've tried, it is very challenging to get someone admitted to the Sunnybrook Center, unfortunately. Again, they are doing this or have done the same protocol that we've done in MR-FUS. And so we have a lot of a good relationship with that group, but they still won't let our patients in, considered out of province. So.
Question from Rebecca Ponting. In terms of severe to moderate OCD, can patients' medications be managed with their GP, or would specialist psychiatric treatment be essential?
I think an initial consultation with a psychiatrist who understand, and not all psychiatrists do understand how to use, if I'm honest, use medications appropriately with a high enough dose. And so I think an initial consultation would be really helpful. And that's what often I'll do. I have an anxiety, or I work in the anxiety disorders clinic at the Foothills Hospital here. And so what I'll do is manage the medications and then liaise with the family doctor, and so they feel comfortable with the higher doses. And I understand if you're a family doctor, you're not always comfortable with pushing the dose. And so I find an initial consultation with psychiatry is really helpful.
Okay.
The right psychiatrist.
Any thoughts about OCD versus OCPD and how treatment approaches differ?
Yes. And so, we struggle with that. Thinking about myself, do I have a bit of OCPD? Probably. So again, what is personality and what is adaptive versus what is a disorder? And so I always try to understand that difference. And so if it really is impacting their life and it's disruptive, both at work and in relationships, then I would consider that to be the disorder. And that's how I would approach what we've talked about today. If someone is more on the personality side and is, fastidious, I guess is the word we use, or, different things we use to describe people, perhaps some cognitive behavioral therapy along those lines might be more appropriate. Maybe issues around control might be part of it as well on the personality side, which I think would be different than the disorder.
Okay, and there's another question by direct message to me. Are there any ethical concerns regarding utilizing ERP with clients who have sexual pedophilia obsessions? How should one navigate this?
So, what I think is a tragedy is people not understanding the obsessions related to OCD, especially when they're moralistic or reprehensible. So, sexual, aggressive. I have a cadre of patients, of young females. They're in their 20s, and they have obsessions about being pedophiles. Now, how absurd is that? Right? And so they can't babysit. They worry that they're going to harm the child in some way. Not educating the family is critical because parents jump in and think, oh my God, this is terrible. We've got to get this person help. This is, pedophilia. And so I just caution you to make sure, and that's why history and talking to people is so important, because you have to understand what it is they're worried about. And understand that in these obsessions, they never act on them. So they worry about it. Another common one is self-harm. And that's a tough one to distinguish. Are they actually going to harm themselves? Are they actually going to commit suicide? No, but they worry about it. And so those obsessions go over and over. And I've seen unfortunate patients being admitted and then they're on suicide watch. Well, they would never commit suicide. It's the furthest thing from their mind. But if you only tick the box and say suicidal, yep, that's what happens. So they obsess about it, but they would never act on it. So the same thing with sexual disorders, pedophilia, they obsess about it. The patients that I treat that have OCD do not act on it.
Next one, I work in an early psychosis program, and we have a few patients who we suspect have antipsychotic induced OCD symptoms. Would the treatment differ?
Very good question. So when I came to Calgary, I started working in the early psychosis program, having come from Edmonton, treating everybody with OCD. And so you're absolutely right. Our antipsychotic agents induce serotonin because they block serotonin, can cause OCD symptoms. It's very common. It's very challenging to treat. And the treatment is the same. So you still use an SSRI. I often start with sertraline in the patients who have psychosis, and again titrate up accordingly. It can be very difficult to treat because of the dopamine blockade with your novel antipsychotic. So when I was early in training, we didn't use some of the newer antipsychotic agents, and with the advent of those, you do see serotonin blockade and the emergence of OCD symptoms. I have a cadre of those patients as well. So same treatment profile, very resistant. And so often again, ERP can be useful.
Okay, just very quickly, I'm wondering about distinguishing between when intrusive thoughts move from normal to being OCD related. I'm thinking the distinguisher would be the score on the Y-BOCS and whether the intrusive thoughts are occurring constantly and distressing.
Absolutely right. Yeah. And that's the distinction. Because sometimes, you say, I can't get that out of my head. That's different than hours spent in obsessions and compulsions. And the Y-BOCS score will tell you 1 to 3 hours a day, 3 to 8 hours a day. Imagine that. Very distressing, very disruptive to their life. And that would be the distinction. Correct.
And
You
quickly,
answered your own question.
sorry, last question there. Are you noticing an increase of ASD with OCD patients? Is the treatment the same?
Um, I think we have to be careful and speak to just treating what is OCD. So I think I'd like to stick to the definition of what OCD is, so that, you know, there's distinct obsessions, compulsions associated with it, and stick to the very defined nature of OCD. There's a number of disorders that can be comorbid, that overlap, and I think making those distinctions is important. So if there are OCD symptoms, as I've described, obsessions, compulsions, to the degrees we've been describing, then I would treat accordingly.